Shame in Healthcare and Bioethics Workshop Series. This is jointly organized by myself. I'm Supriya Subramani. I'm a postdoctoral fellow at the Institute of Biomedical Ethics and History of Medicine at University of Zurich, and Professor Luna Dolezal, Associate Professor in Philosophy and Medical Humanities at University of Exeter. And this workshop is funded by Wellcome Trust, Shame in Medicine project. So, key takeaway, I'm sure you would have heard about the workshop series, but still the thing which we are focusing is trying to engage critically with conceptual and phenomenological understandings of respect, disrespect, and shame, humiliation, and of course, related concepts by bringing together scholars from different disciplines and frameworks. So, we hope to understand these concepts from multifaceted understanding, and also which we can contribute to both healthcare research largely and also bioethics discipline itself. So before moving to our first session, just housekeeping information I would like to share. The workshop will be recorded and a copy of it will be sent to you all, and it will also be uploaded on YouTube. And the format of this session is the speaker will be giving like 30 to 40 minutes of the talk, and then they'll be followed by discussion, which we can have even a short Q&A session. And then there will be a 10 minutes break. And then we have another session, a talk, and then we have an open discussion with an audience overall. And the feedback will be given after by the discussant Barry to Nataliya. And if you have any questions, please use the chat box, or also please raise a hand and we can have a free-flowing discussion around this. And on a final note, there will be a special issue in the Journal for Evaluation of Clinical Practice, which is arising from this workshop series. We are pretty happy about that. And we have opened the call for submissions. So please, if you're working around these concepts, we look forward for your submissions. And today, Barry will be presenting the presenter, the keynote speaking on stigma and the mental health of healthcare workers. So Barry Lyons practices in the Department of Anesthesia and Critical Care Medicine at Children's Health Ireland, where he is also clinical lead in patient safety and chair of the Hospital Ethics Committee. He is director of patient safety at the College of Anesthesiologists of Ireland. His research interests relate to the role of negative emotions in medicine and the interface between law, regulation, and medicine. He is also the collaborator on the Shame and Medicine project, along with Luna Dolezal. So looking forward and pretty excited to listen to Barry, and over to you, Barry.
Thanks, Supriya. Thank you. Okay, I'm going to hopefully share my slides. Okay, can everybody, you see those? Yeah, brilliant. Thank you. Okay, good afternoon, everyone. I would like to thank Supriya and Luna for inviting me to speak here virtually today. I have some confessions. A few years ago, after Luna and I presented at a conference in Durham on, I think it was shame as an effective determinant of health, a psychiatrist came up to me afterwards and asked me, what was I doing in this space? It was a question of curiosity, but also, I suppose, an indication that I might be transgressing into an academic environment in which I might not have had any specialization. So I am not a mental health worker. I am not a phenomenologist. I am not a sociologist. Instead, I am an anesthetist, an intensivist, and I suppose a bioethicist. So why am I talking about this topic today? Okay, let me see. Okay. So my interest in it really was stimulated, I suppose, by personal experience. A couple of years ago, this rather clunkily titled consensus paper was published by the Association of Anaesthetists of Great Britain and Ireland. And it was in response to what was regarded as an increasing incidence in suicide amongst, I suppose, my specialist community. And a couple of years before this was published, we had 2 trainees who had died, one by suicide and one by accidental overdose. It was devastating, really, within the community. And so there was an increased focus on the mental health of trainees and of anaesthetists in particular. So why might this risk be there? It's postulated that it's because of high physical and mental demands, fatigue, uncontrollable long hours, shift working, social professional isolation, for trainees, examinations, rotations away from home. There's speculation around particular personality types, those of a perfectionist or obsessional nature. But there's also broader issues relating to a reluctance to seek medical help. So doctors are poor seekers of medical help and tend not to seek help until it's quite late in any illness. And it's at this point that they mention stigma. It is one of the few mentions of stigma within this paper, and it's not really elaborated on. Anaesthetists also have other, I suppose, occupational hazards. There's a particular ever-present risk of serious adverse patient outcome, and then substance misuse because of access is more likely in anaesthetists. And they also have the access to and power and knowledge for access to the means with which to take one's life. So it is a particular concern within our community. A secondary, I suppose, entrance point was this study here, which was one of two that we carried out in the first wave of COVID in intensive care units. And the findings aren't that relevant. We didn't find anything that you wouldn't expect in that kind of a stressful environment. But one of the things that came out of it came really in the free text elements of the responses. And that was that people were happy to look for peer support even when significantly distressed, but very unhappy to access formal structures of mental health caregiving. And the reasons for that appear to relate to stigma, which is what I'm going to try and explore. So when you Google mental health and stigma, one of the first hits that comes up is this. And so in 2014, following the death by suicide of Robin Williams, journalist and author Elizabeth Day wrote an article on stigma and mental health. And it started with no apparent sense of irony by acknowledging the media's tendency to invade the personal lives of celebrities, and particularly those who are deceased. However, it suggested that the voluminous outpourings of journalists, bloggers, Twitter were sufficient proof that the concept of stigma has no longer any application in respect of mental health, but rather should be reserved for truly scary incidences of physical decline. Indeed, from Day's perspective, the linking of stigma and mental health is in itself harmful. Unfortunately, data clearly indicates that the desire for social distance from people with mental illness has not really decreased over the last number of decades amongst the general public. And the historian Roy Porter described the history of psychiatry as an orgy of stigmatization. And regrettably, for many people with mental illness, including those with common disorders, they continue to experience discrimination frequently in their daily lives. There appears to be an increasing prevalence of mental ill health among the medical profession, including GPs, much of which has been attributed to the items or issues that I stated earlier. Psychological difficulties or distress experienced by doctors can be further compounded by self and societal stigmatizing associated with an inability or perceived inability to cope. The prevailing dominant culture among medical practitioners is one of non-disclosure of vulnerability, with consequent avoidance or delay in divulgence of problems or of help seeking. So when we talk about stigma, discussions traditionally take as their point of departure the now classic work of Erving Goffman, who defines stigma as an attribute that is significantly discrediting, which in the eyes of society serves to reduce the person who possesses it. Drawing on research experience with people suffering from, amongst other things, mental illness, possessing physical deformities, or practicing what were perceived to be socially deviant behaviors, Goffman argued that the stigmatized individual is thus seen to be a person who possesses an undesirable difference. He contended that stigma is conceptualized by society on the basis of what constitutes difference or deviance, and that it is applied by society through rules and sanctions, resulting in what he described as a kind of spoiled identity. The stigmatized are at risk of being ostracized, devalued, scorned, shunned, and ignored. Those that perceive themselves to be members of a stigmatized group often experience psychological distress and view themselves negatively. Since Goffman, a significant number of publications in relation to stigma and mental health indicate that this has become a fertile research field, although it is one that seems to pose lots of questions and provides rather fewer solutions. Out of such questions, multiple and multidisciplinary theories and definitions have emerged. One of the more influential models is that of Lincoln Phelan, which places stigma firmly within a paradigm of power dynamics. Fundamentally, it describes the labeling of human differences that are perceived to be negative or adverse, and the separation of the group of individuals who possess these characteristics from the rest, termed by Goffman as normals. So stigma, according to Lincoln Phelan, exists when four specific components converge: the differentiation and labeling of human variations, prevailing cultural beliefs tied to those labels, being separated out as into us and them, and the labeled individuals experiencing status loss and discrimination leading to unequal circumstances. According to Corrigan, stigma comprises of four social cognitive processes. Firstly, there are cues such as psychiatric symptoms, social skills deficits, physical experiences, and labels such as clinical diagnosis that may suggest the person has a mental illness. Cues trigger cognitive associations with stereotypes that are negative, i.e. knowledge structures about a marked group related to mental illness. Commonly held stereotypes against those with mental illness include incompetence and perceptions around mood, instability, and the possibilities of violence. People, either as outsiders or those with mental illness, can believe in these known stereotypes or reject them. If they endorse the stereotypes, they develop prejudice against those with mental illness, a cognitive and affective response. Discrimination is the behavioral manifestation of prejudice that occurs when those with or those believed to have mental illness are treated differently. Discrimination can occur by others towards those with mental illness, or even within an individual themselves, i.e. self-discrimination. For example, in employment terms, a stigma might lead a person to not apply for a role if they believe that the employer might discriminate against them during the hiring process, or if individuals with mental illness do not apply for the role because they believe themselves to be incompetent. Within the model, Corrigan identified two types of stigma associated with mental illness that impede seeking mental health care: public stigma and self-stigma. Public stigma comprises of beliefs, responses, and behaviors that the public, i.e. other people, may exhibit towards the group of individuals with mental illness. Public stigma and self-stigma are related but slightly separate concepts, and I'll come back to self-stigma in a second. And Vogel and Wade propose that apart from the stigma associated with mental illness, the stigma associated with professional psychological help and the seeking of that implies weakness and failure, or can be seen to imply weakness and failure on the part of the members of the stigmatized group, which in itself inhibits help seeking. So people may wish to avoid the label of mental illness because of stigma's potential effects on one's sense of self. Living in a culture steeped with stigmatizing images, persons with mental illness may accept these notions and suffer diminished self-esteem, self-efficacy, and confidence in their future. Research shows that people with mental illness often internalize stigmatizing ideas that are widely endorsed within society and believe they are less valued because of their difficulties and agree with the stereotype. That's right, I am weak and unable to care for myself. Obviously, this kind of self-prejudice and self-discrimination significantly interferes with a person's life goals and general quality of life. Clement et al. Outline, again, a set of different categories of stigma that have been identified in the literature. Anticipated stigma, or the anticipation of personally being perceived or treated unfairly. Experienced stigma, the personal experience of being perceived or treated unfairly. Internalized, holding stigmatizing views about oneself. Perceived, participants' views about the extent to which the general public have stigmatizing attitudes or behaviors towards people with mental illness. These may be endorsed by the persons themselves, and of course, as I said before, the stigma associated with accessing or receiving treatment for mental ill health. So, while stigma unfairly prevents people from reaching important life goals due to discrimination, it also has significant internal consequences for the cognitive and emotional functioning of individuals with mental illness. And this includes significant stress, particularly when the perceived stigma and the stress associated with it exceeds one's personal resilience. And that, in addition, is associated with a sense of shame. The relationship between stigma and shame is often under-evaluated, although referred to by Goffman, and has been, I suppose, most extensively examined through the work of Graham Scambler, and I suppose most recently by Luna Dolezal in a recent publication. So a health-related stigma may be visible, such as a disability or disfigurement. However, it may also not be immediately perceivable. In other words, some health-related stigmas, such as mental health issues, may be easily or readily concealable. In the latter case, the individual bearing the stigma, the person is not yet discredited, but is discreditable. The awareness of inferiority means that one is unable to keep out of consciousness the formulation of some chronic feeling of the worst sort of insecurity. And this means that one continues to suffer anxiety and perhaps something even worse. The fear that others can disrespect a person because of something he shows means that he is always secure in his contact with other people, according to Goffman. And this insecurity arises from something he knows he cannot fix. In contrast to the broad lack of clarity regarding the relationship between shame and stigma, Graham Scambler explicitly discusses shame as a key experiential component to stigma in his article, Reframing Stigma. Scambler aims to describe how living with a stigmatized illness impacts upon the biographies of those diagnosed, as he shifts the analysis to a first-person perspective. Scambler discusses felt stigma as a means to differentiate the experiential aspects of stigma from the social phenomena attached to it. He suggests felt stigma has two references. First, the shame associated with being reduced to the condition, and second, the fear of encountering enacted stigma, where enacted stigma refers to acts of discrimination. Enacted stigma is, for Scambler, synonymous with shaming, and he posits that shame and stigma are internally related. According to Dolezal, living with shame anxiety does not mean that shame is experienced continuously, but instead the threat of shame is predominant and persistent. There's a crucial distinction between the actuality of shame and the potentiality of shame. Living with a stigmatized, invisible chronic illness involves both actual shame and potential shame. And following Scambler's structure of felt stigma, there's a shame related to one's illness, actual shame, and the fear of enacted stigma where one is afraid of social rejection through discriminatory actions. Shame anxiety is the experience of potential shame or the shame that is anticipated when one is afraid that one's concealed illness will be discovered and one will be judged, scorned, or ostracized. The stigma of mental health represents obviously internal phenomenon, but also a significant barrier to accessing appropriate care that impacts upon almost all social groups. This diagram with its overlarge stigma balloon is from a study of young elite athletes. Around the same time as Day was penning her article for The Guardian, a group of researchers at King's College were trying to identify just how much of an impact stigma had on individuals seeking help. And they conducted a systematic review of quantitative and qualitative studies. And they identified a small to moderate sized negative effect overall. But this impact was significantly higher in particular groups, particularly amongst military and healthcare professionals. And they put this down from the review of the research to this sense of an ethos of invincibility in medicine and to machismo in the military as reasons why these groups were particularly deterred from health seeking by stigma. And so it seems that if we sort of cross-fertilize these high-risk groups, then we might come up with a subject worthy of examination. And a significant amount of work has been done on, I suppose, what might be considered the ultimate problem, which are military doctors. So compared to other groups, military doctors in general report fewer mental disorder symptoms than other comparison groups. So who are these comparison groups? Well, the comparison groups are people who serve in the military at the time but are not medically qualified, or people or ex-servicemen. So they are army personnel. So military doctors endorse higher levels of stigmatizing belief, have more negative attitudes to mental health care, have a greater desire to self-manage, greater self-stigmatization, most concerned about the potential negative effects and peer perceptions of receiving a mental disorder diagnosis. And those with alcohol or mental health problems were significantly and substantially less likely to seek help than the comparison groups. Slightly less dramatic, but similar findings are identified in qualitative research around general practitioners. 2/3 of general practitioners in one study reported that if they were experiencing mental health problems, they wouldn't want anybody else to know, particularly their colleagues who they work with. There's a sort of unwritten rule that you don't admit to mental illness in practice, even though everybody knows that everybody has it. It's just not talked about. Mental illness is regarded as a failure with an eye towards medical education and training. You're not groomed to be a LARU. You're not groomed to be a failure. And the perceived stigmatizing attitudes of colleagues to patients with mental illness, and this will be familiar to anybody with a significant mental illness who has attended particularly an emergency department amongst other locations, is also a barrier to GPs seeking help. It's about the voices I heard from GPs saying, I know, you know, all they have to do is pull themselves together, or all they ever want is pills. Amongst the many remedies that are suggested, mostly ineffectively, for reducing social stigma towards mental health diagnosis, the suggestion is that we increase mental health literacy. Under those circumstances, we would expect people who are most mental health literate to have the least stigmatization or self-stigmatization. So when we examine health seeking for mental health problems by mental health professionals, we find actually that they are not much better than the general population or the medical population in general. So there is a significant difference between what people propose they might do should they become mentally unwell, and what they actually do under those circumstances. And the reported barriers, again, to seeking help are wanting to solve one's own problems, fear of colleagues finding out, and this latter one here, which we will return to, the potential for negative consequences relating to the regulator. Although in general, health professionals indicate less stigmatizing attitudes towards people with mental illness than the general public, some of the issues are still pervasive. They share a similar desire for social distance. They demonstrate similar or even higher levels of self-stigma. They're less likely to accept a mental health condition in themselves. They're less optimistic about recovery from serious mental health problems, and more likely to believe that an individual with serious mental health condition would experience discrimination and stigmatization. And that may be because of the environment within which they have developed as a professional. So the last bit that I want to touch on in this presentation is this notion of structural stigma. So far we've really talked about the internalized process of felt stigma, of related emotions such as shame, of how stigma is perceived, but not so much about how stigma is delivered. And so I just want to spend a little while talking about structural stigma. So structural stigma relates to those either state regulatory or institutional policies or practices that impose stigmatizing conditions upon individuals. Link refers to the underrepresentation of structural stigma as a dramatic shortcoming in the literature on stigma, as the processes involved are likely to be major contributors to unequal outcomes. So societal level conditions, cultural norms, and institutional policies and practices may constrain the opportunities, resources, and well-being of the stigmatized. So what do these look like? Well, one of them is a regulatory phenomenon, and this is what is something that is prevalent within the United States in particular. Within the United States, many professionals are required to report any mental illness diagnosis or treatment to their state licensing board. Although in some states, the questions are limited to illness which impairs or may impair the work performance, other states ask blanket questions about whether the physician has been diagnosed or treated within the last 2, 5, 10 years, or even in their lifetime. A relatively recent review found that 42 of 51 state licensing applications had questions about mental health. Physician disclosure of such a diagnosis, even for a common, stable, and easily treatable lifelong condition such as anxiety or depression, may lead to a range of adverse consequences depending upon the state. These can range from simply being required to submit a letter from the primary treating provider to which documents fitness to practice, to being asked to appear before state board examiners, to being required to undergo and pay for an examination by a board appointed physician, provide extensive or ongoing medical records, enroll in a physician health program, pay for inpatient or intensive outpatient treatment, followed by long-term monitoring, or agree to restrictions of practice. So it's unsurprising that amongst this large group of female physicians, only 6% with a formal diagnosis or treatment of mental illness had not disclosed it to the regulator. And they undertook a series of concealing activities. This includes not seeking treatment for their problems, traveling across state lines to get medication, going to clinicians in another town so it wouldn't be noted by their institution, and generally taking, I suppose, courses that would avoid the regulator becoming familiar with their mental health issues. So the power of the regulator to influence the behaviors and to, I suppose, re-stigmatize those with mental health problems is one element of what we might consider to be stigma power, and something that is, I suppose, was most extensively originally discussed by Lincoln Phelan in 2014, and most recently by Imogen Tyler in her book on stigma and inequality. The role of the economy and the state in defining, publicizing, and devising sanctions to control deviance and stigma, I suppose, is relatively well documented, especially in relation to policy formation, whereby illness tarred with the brush of stigma provides yet another dimension of negativity. Not only does a constitution afford opportunities for deviance, but it is evidence also of a deep inadequacy or imperfections in its bearer. In addressing these issues in relation to HIV and AIDS, Parker and Aggleton rejected really the individualism underlying conventional approaches to stigma and its alleviation. And instead they insisted that stigma and stigmatization functions quite literally at the point of intersection between culture, power, and difference. And it is only by exploring these different categories that it becomes possible to understand stigma and stigmatization, not merely as isolated phenomena or expressions of individual attitudes or of cultural values, but as central to the constitution of the social order. The relationship between organizational or corporate interests, power, and stigma manifests itself in particular ways in contemporary medical practice. One of these ways has been the more recent focus on resilience, which is known to pretty much anybody who works in a corporate, academic, or healthcare facility. And it's well known that institutions often turn a blind eye to dysfunctional workplace characteristics that promote burnout and have negative employee consequences. It is much easier for the corporation, and this is particularly true within the healthcare environment, to place the responsibility for self-resilience on individuals rather than by modifying the workplace. It is important, certainly within healthcare, to recognize that we are only important by virtue of our productivity. And changing the workplace is significantly more difficult than replacing individuals. The whole institutions to spend less time holding wellness and resilience seminars and spend more time correcting institutional causes of burnout. And just finally, the latest version of resilience that has appeared is that of grit. And this is a series of papers about grit in surgeons. And it's about toughness, and it's about survival. And what we seem to be doing is moving away from perhaps what might be desirable elements within a clinician, those of empathy, kindness, of caring, to those that enhance survivability. So these relate to differences in grit between gender or between generations. And what we identify from them is that grit is contested in terms of its whether people who are older have more grit than people who are younger, or between genders. It is an interesting manifestation of, I suppose, power within institutions, that there is now a move within medical schools to assess individuals for qualities such as grit prior to enrolling them in medical school. The relationship between grit, which is an indication of capacity to survive, and other, as I said, other qualities, is as of yet indeterminate. So there is, within that, it seems highly improbable that any individual medical student manifesting or possessing a mental health problem would be desirable in the world of grit. So to summarize, and I apologize for wandering around there, mental health stigma persists in the world of healthcare professionals. These concepts remain persistent. Getting a diagnosis would be embarrassing or shameful. People are afraid colleagues would find out. The diagnosis renders an appearance of incompetence. And there's this sense that mental health issues are not something that happens to real physicians. And if they do, then it's something that they should be able to manage themselves. And that's it. Thank you very much.
Thank you so much, Barry. This is an excellent way of bringing up like how you just show the way it's important to not blame an individual, but look at the larger structural issues and factors which plays a significant role and not stigmatize. And then there's an interlink with also which you showed with the gender ideas and how gender plays a very important role also, and how people, you know, whether they seek mental health or not, and how the stigmatization process works in itself. So the floor is open for the questions, and please. If you have any questions, we can. Yeah, please, Luna.
I don't mind starting, so I'm going to keep my camera off. I was really interested, Barry, in the bit about the bringing the military and medicine together, because it's one thing that I've spoken to Will Bynum about, because he's a physician at Duke who studies shame in medical learner experience, and he wrote an article about his experience in a military medical environment versus just an ordinary medical environment. And it was really interesting. I think, Penelope, you might have been there for that conversation. Really interesting how he said actually in a military environment, there's actually a lot more psychological safety than in an ordinary medical environment, because the training is much more centered around team building and like being okay with fear and vulnerability and all of these things. And I don't know, I'll put the link to the paper. I think it's more like an opinion piece where he compares his experiences of both these training environments. I'll pop it in the chat. So, I mean, it's not really a question, it's just kind of a comment, because it surprised me then to see the statistics from that other paper, or the findings from that other paper that you mentioned, because it seemed somewhat at odds with his account, which obviously is just his account. But I wonder if you have any thoughts about that.
Yeah, so that other paper is by it's from the UK. So, you know, perhaps there are differences between military forces in different countries. It's by Neil Greenberg, who is a military psychiatrist and has done quite a lot of work on mental health and mental health issues within the armed forces. And certainly within that, there seemed to be clear data that doctors working within the armed forces experienced quite significantly higher sort of degrees of particularly self-stigmatization, reliance on self-treatment, and a distinct reluctance to admit to any mental health issues, even when they were present. And that was, I suppose, in comparison to other members of the armed forces. The levels of self-stigmatization appear to extend well beyond those of ordinary soldiers, but also of doctors within I suppose more standard practice environments. So I'm not quite sure why the difference is there, and like I say, there might be different cultural environments in different armed forces. I don't know if anybody else has any experience of that.
Yeah, it'd be interesting to speak to Will more about mental health stigma in particular, because his reflection, I think, focused on like making mistakes and the vulnerability and shame around making mistakes, which I think maybe is a different category of experience and perhaps far less stigmatized. So yeah, I would definitely ask him next time I speak with him.
Yeah, it would be interesting. Yes, I suppose that is, and again, it might be that you know, in terms of error, that the armed forces are a little bit more like airlines, and willing to sort of engage in a more structured review of when things go wrong in order to make sure that they you know, that there's not a recurrence, and so that might be, you know, less stigmatized within that kind of military environment where operational matters are of, I suppose, of paramount importance, as opposed to general perceptions around the mental health of individual practitioners.
Yeah, thank you, Barry.
So we have Dawn and then followed by Penelope.
Hi, Barry, thank you. That was a really interesting presentation, and I'm glad you have made the decision to explore areas that maybe didn't initially seem core to your area of expertise. I think that's when ideas get really interesting, when people cross assumed disciplinary boundaries. I'm not from a medical background myself, so again, sort of that outsider perspective, and I just wonder what your thoughts are on the impact of the medical model of mental health here. Just some interviews I've done kind of years ago with people managing issues around stigma in relation to mental health. I've noticed particularly younger people sometimes tend to talk more in terms of problems, difficulties. We all have difficulties, without actually conceptualizing that as, have you got a mental illness or not? We know that a lot of distress is on a continuum, and it's arguable exactly where you draw that line. For some kind of issues, there does seem more of a dichotomous distribution, but for most not. And I know, you know, sometimes people feel that to actually name something as a mental illness, that's a way of combating stigma and recognizing an illness like any other. You know, but there's research showing that can affect the way we conceptualize a problem, see it as more chronic, see people as less able to change. But it was just striking me, you know, talking about within a medical context, does it mean that if you adhere to a kind of more medical diagnostic understanding, people have stepped over that boundary, you are now other, and whether sometimes it can be helpful maybe to think in terms of resilience, coping, distress, rather than in terms of mental illness?
Thank you. Hello, Don. It's lovely to meet you. I've read your work, so it's really nice to to see a face.
Likewise. Yes.
Yeah, it's an interesting thing, and I suppose you could say the same about medical models for very many sort of forms of diagnostic categories, not just sort of in relation to mental health, and how I suppose the medical model is sociologically contested across many domains, and entirely reasonably, and in many cases, and it's an interesting thing because I mean, there are many things I could say about it, but there are also contests within that, because, and this isn't speaking about psychiatry, but there are many people who seem to like a label, who seem to need a diagnostic label in order to feel that they can control their illness themselves, and so non-specific labeling may not help that category. And I don't know how we find a balance between medical models and more sociological models that actually suits an entire population. And I think it's one of the difficulties we face. I do agree, and I think, and I wonder, and you may well have an opinion on this, is around the change in, or the different language that we now have when we talk about burnout and stress, which have suddenly become acceptable things to discuss within a healthcare environment, as suffering from burnout and stress is some way okay, but psychiatric labels are not okay. So people will rarely reveal that they have depression, that they have significant social anxiety, that they have OCD, but burnout seems to be a catch-all phenomenon within which people can hide and actually discuss their personal distress without necessarily feeling as stigmatized as they might have done in the past. And again, there was, I think, I mean, I think you're absolutely right. I think it would be nice for people just to be able to articulate distress without there being a label attached to it, and for us to be able to provide care and assistance for those individuals and support under the circumstances. People are very, and it's interesting how reluctant still healthcare workers are to access formalized supports. And that came, I suppose, from our study during COVID. So within Ireland, there's a thing called the EAP, which is a free counselling service that is offered to all healthcare workers. It is entirely separate from the organisation. It is entirely confidential, so your employer has no knowledge of your accessing it. So you can do so in complete secrecy and in confidence, and yet the uptake and usage of it is very low. And that sense of self-stigmatization for weakness, and that belief in that healthcare workers should be able to cope and manage, is something that remains pervasive. I'm not sure if I actually answered your question in the midst of all of that.
I think those were some really interesting observations, and I agree. I think you're right. We need kind of a variety of ways of talking about what people experience, and that different ways of talking about it are kind of more or less helpful in terms of stigma in different contexts. And what you were just saying there about people feeling that they can't cope. And actually sometimes labels that define something as kind of extraordinary, outside the realms of normal experience, can help to kind of justify people's sense that they're not coping, because without the labels, and using terms like burnout, stress, etc., that is the risk, that then people are exposed to having to justify why they feel that they are not able to cope with the stress in that situation, because we do have a rather individualized idea about coping and stress sometimes. But yes, I think you're absolutely right. How do we have find a language for talking about this that's appropriate for a wide range of people. But yeah, I can see there's other people wanting to ask you questions as well.
Thank you.
Thanks, Dawn.
Please, Penham.
Thank you so much. This was so interesting. And I'm doing my best to formulate an actual question. But so I was really struck by the chart about stigma power, and how that's sort of moving from the institutional to the interpersonal to the just personal levels. Especially now in this context of the conversation you've just been having about how certain discourses are sort of taken up by the power structure, by the institution, and then become okay or neutralized maybe by the, by the conversation around burnout. Now that's suddenly part of kind of what's okay to talk about. I guess the question is, what do you think about how, in the context of these institutional power structures, and given that medicine is so hierarchical, individuals internalize or are taught to kind of feel this self-stigma through the power structure, and then what circumstances or qualities or organizational quirks then promote or allow for resistance within that institutional power structure?
Yeah, it's the latter part is difficult to answer. I think it's a really interesting thing that when people first enter into medical school, and it's there are different models here perhaps than there are in North America. So for example, people may enter medical school at the age of 18 as opposed to after a primary degree. And almost the first thing they hear when they enter medical school is that, medical training is tough. I mean, it's articulated it's almost the first thing that they hear in the first day. And it becomes then about survivorship and how are you going to manage and how are you going to, and there's a real emphasis on, I suppose, self-resilience. And that is, and so there's an offer for all sorts of things, and we get this in hospitals as well. And it's really interesting how ableist they are. We're going to so you can have yoga or Pilates or whatever it is at lunchtime on a Tuesday, and so we are giving you tools to make yourself resilient. So there's a throwing of indiscriminate tools at people to sort of say, now we have given you those tools, and so you should now be sufficiently resilient to manage. And it's very difficult to argue within the corporate structure against that imposition on the individual. So we individualize this, we create this self-reliant system that is really problematic, and it's completely distances people from a kind of a supportive community, which is, I think, would be a much healthier structure in terms of people depending upon each other. And I suppose in many ways that perhaps represents a gendered idea of how these things should be done. I think that, as some of my colleagues say, that if women were in charge, we would be creating communities of caring rather than self-reliant, powerful individuals. And I think there's probably something reasonable to be said about that. It is everything has a cost. And within corporate structures, it's quite difficult to argue for things that are not, don't carry a straightforward utility or perception of something that's measurable. And communities don't really carry that. They don't carry that cachet. They don't carry something measurable. and in my experience, I don't have an answer to this. So if you have an answer that tells me how to change my organization's culture to be more receptive, I suppose, more acknowledging, more interested in communities, then I really would be delighted to know how to do that. But it's an uphill battle, and I would imagine it's the same in most environments. Do you have an answer?
No, but I think it's interesting just to think about how it's the sort of, as you've said, the uphill battle. It's the as ideas are taken up by the institution, then there's the constant need for further pushing of what's possible.
Yeah, I think this sort of individualization, this sort of increase in publications around what it takes to survive as an individual is disturbing, I think, in many ways, and a retrograde step from trying to, so you know, if we end up creating some metric that allows us just to recruit people who have grit, it would be interesting to see how that translates into care.
Thank you. So we have a question from Jonita. Jonita, I'm sorry for the pronunciation.
Hi, Jonita. How are you?
Hey, how are you?
Good.
That was a brilliant presentation. Thank you.
Very kind. Thank you.
So I have a question, but also it's one of those questions where I ask you for a solution to a larger problem. So it's just, you know, so bouncing off ideas. I thought it was really telling how you started your presentation discussing the impact apparently that Robin Williams's suicide caused on the whole conversation on stigma and mental illness. But at the same time, in such a context where you would expect that the conversation would be more open and more frank, you also mentioned how even like the solution that was provided, let's say from the medical side, which was, you know, normalizing this type of thing and giving access to more knowledge on mental illness, was actually not working because, as you mentioned, healthcare workers are still very much embedded in an awful circle of shame, which is, you know, reinforced then by the by the context and environments and policies that they have to deal with. And so a little bit of my question and my approach to this is, I see that maybe the inner side of medicine is trying to come up with a solution that is actually not happening. Could you see that maybe outside effects, context, I don't know, more social awareness, like the one that was brought up by, you know, Robin Williams' suicide, and there's been many other cases of really famous and beloved people who have gone that way, who have opened that questioning. Yeah, and my question also comes from a place where right now I'm very interested in studying the relationship between popular culture, medicine, and the ideas that exchange generates on the global public, you know? And a lot of the way in which illness and is conceived is very much informed by medical professionals. But from what I've read, there's also a lot of the popular ideas invading a little bit the medical spaces. So I was wondering if you could see that maybe a wider change in society could propel medical professionals towards a more gentle approach, or if it's definitely the science-informed people who will have the last word on this.
I think there's so many things to say about that. So the first is like, why is Elizabeth Day wrong? So if everybody's talking about it, then why does mental illness remain stigmatized? And there's no doubt, you know, there's increased traffic of mental health discussion across a whole variety of media. And I think so there's a few things that seems to happen in combating stigma. The first is when people, I suppose it's called protest, when people protest against inaccurate perspectives on mental illness, and so around things like incompetence, and around things like violence, and around things like people's fear of living next to somebody with a significant mental illness. So that's one thing. And the second, which is, I suppose, also common, is education. And you could say that articles like that serve an educated sort of framework. The problem, I think, the counterbalance to that is it comes from institutional power, and that's the power of governments to resource mental health care. And I think certainly in Ireland and the UK and probably many other jurisdictions, mental health care is grossly underfunded, and has been for 100 to 200 years. And so the provisions are often in poor facilities, in under-resourced environments, in a lack of access to care. And so on the one hand, governments may run educational campaigns that seek to destigmatize, but on the other hand, they re-stigmatize by identifying these communities as not being worth it. And so sending messages is cheaper than resourcing effective care. And I think that sort of two-handed message is implicitly recognized by communities, that people with mental health problems are not worth something. The other thing that comes through, and Patrick Corrigan, who's written an enormous amount on mental health stigma, and he's as both an academic and practicing psychologist, but also somebody who has a significant mental health problem, and who writes very personally about his mental health issues. And he said that one of the issues that he finds, and it's one of the things that distresses him most, is that when you disclose that you have a mental health problem, that you automatically become the subject of pity. And when you are the subject of pity, you are automatically reduced in the eyes of those who pity you. And so you may not be stigmatized in the more traditional way, but you are still stigmatized as being somebody who is of a lesser value, through that sense of pity. Again, I'm not sure how. So education and literacy can work. So they did some studies, and the other thing that seems to work a little bit is contact. So when somebody comes and recounts their personal experience, and it's a personalized version of what it's like to be somebody with a significant mental illness, then that can also impact significantly. And there's somebody who's I'm just trying to, so in Ireland, we have a rugby player called Keith Earls, who's just written a lot about his personal battles with mental health, and that has led to an increase in referrals, or an increasing number of people trying to access mental health services. So there's a direct correlation between that sort of sense of contact and access. The problem is that that's not sustained. So studies that they've done on medical students, where they have brought somebody in with a significant mental health problem who speaks to medical students and personalizes a mental ill health in a way so that they can see what it does to an individual, has an impact, but it's not a sustained impact. So by the end of 6 months, then that impact has waned off as something else has replaced that person in their sort of cognitive sphere. So it's like any sort of change management. It's you can make it, but sustaining it is something that's incredibly difficult, and it requires governmental investment, both in both physical and also, I think, in a very vocal kind of a way, in terms of indicating that people with mental health problems are us.
Great. Thank you, Perry. I can't just, I mean, I know we are running out of time, but I'm trying to ask a quick question on what is the role of bioethics and especially particularly on ethics committees within the, organizational setting. What do you think is the role it could play for reducing the stigma? Do you think so?
Oh, that's a really interesting question. I don't, oh gosh, I don't know. And again, I suppose it's a question of what the functions of such a committee might be. I mean, I think one of, in a more general sense, whenever issues come before a bioethics committee or bioethics committees or members do kinds of outreach engagement or outreach sort of education, which I think is a significant role of the job, that idea of respect for persons is something that's incredibly important. And I think that idea of people being valued as individuals, as members of a community, as equals, regardless of any extraneous issues that they have, is, I suppose, probably the easiest and maybe most valuable way of approaching this. That, yeah, I'll have to think about that. That's a good question, but thank you.
Thank you, Barry. And I hope we can continue this, further discussion during the, open session series, of course, after Nataliya, and we can continue this debate, I guess. And we'll have a 10 minutes break. I'm sorry that we are running. I mean, already we are a bit late running, but Can we come back after 10 minutes? Is that okay?
Thank you.
Thank you. Thank you. it's always nice to see to see the video.
It
Definitely.
is.
Yeah.
Yeah.
It is. It's we have some meetings where it's mandatory for people to leave their cameras on, and I think it's quite nice.
Yeah,
Sometimes.
yeah.
I
I
mean,
remember I gave one talk and not even one person was having a video on, and I felt I was talking into a void. Like, yeah.
yeah, it's horrendous. I did a 3-hour teaching session with master's students on Zoom, and all I can see is my slides, and it was the most
Yeah.
awful. And you have to break every 30 minutes because and getting you get some responses, but it's tough. Yeah, it's a tough teaching environment.
Yeah, yeah, that's true. So maybe we can start now.
Yeah.
Okay, great. So we have our second speaker, Nataliya Shok, and she'll be presenting paper on medical error as a stigma, the moral code in healthcare practice and bioethics in Russia. So Nataliya is a professor at Privolzhsky Research Medical University. I'm sorry for my pronunciation. She's focused on research of ethical issues in health, healthcare, and the life sciences with particular attention to interdisciplinary methodology, which she focused from social sciences, history of medicine, and bioethics. Her research interests are on the ethics of organ transplantation, research ethics, and clinical implications of bioethics with a particular emphasis on medical error disclosure. Especially from Russian history and culture of post-Soviet intellectual and political terrain. So over to you, Nataliya, and quite exciting to listen to you more.
Thank you so much for introductions, Priya, and I'm happy to be here because I would like to present my work in progress. And Barry started his talk from explanation why he's talking about what he's talking, and I decided to just give a short introduction why I am talking about medical error, since I'm not a physician, but I'm teaching in medical school for more than 8 years, and the last 6 years I'm interested in bioethics. And so my students, when I first start delivering lectures on bioethics, asked me to provide more interactive environment for the teaching process. And then I started to look for cases to show them more interesting practical things about bioethics. And my first cases were from American journals and British journals. And my students told me, oh no, this is not our problem. These are not our problems. We have different healthcare system. We have different medical training. Well, why don't you just offer us Russian cases? I said, okay, that's a good idea, but I have no Russian cases and nobody published Russian cases. So it's quite an issue to offer to you something which is related to Russian medical environment. And then it was more than 5 years ago, I've started to look for people who will be able to share with me some cases on one hand, and on another hand, to provide me with some medical implications of these cases. And I was just trying to combine these medical and bioethical things towards these particular cases. So here is the unique cases that I've collected from my colleagues, and I would like just to put these cases into broader context of cultural, historical, and social environment of medicine and healthcare practice in Russia. So I would like to share my screen, just a second. And I would be happy to hear some comments if you want to. So do you see my screen? Okay, thanks. So on the first slide, you can see the picture from the medical trial process, I mean, criminal process, criminal trial. And this is our famous physician. She is a neonatologist that she is under the prosecution because of medical error. So I put her a picture on the first slide. The plan of my talk is to talk briefly about methodology, then turn to context about bioethics and some historical introduction, and then the phenomenology of medical error, which is currently exists in Russia. And then I will just introduce you two cases. One is connected to the institutional level of medical error understanding and developing this culture of medical error disclosure. And the second is a personal case from my colleague and friend, thoracic surgeon, who shared with me his personal story. And then I will summarize briefly, according to all these previous points, the levels of medical error stigmatization, because my main point is that medical error in Russia is a kind of stigma. So let's get started. So countries with developed healthcare system are regularly working to improve the quality of medical service and its outcomes, and both error prevention and response. Errors sometimes occur despite the best efforts of people and institutions. But what if medical culture doesn't stimulate medical error disclosure? Do physicians in this case ignore medical errors? And if so, why does it happen? And how does this behavior fit with the medical ethics patterns, professional development, and healthcare quality? Generally, the healthcare system, if it is aware of medical error, use clinical data to create a system reducing the risk of errors. It turns out that it is beneficial for doctors and hospitals to maintain systems for recording medical errors, discuss it, and create standards for their prevention, since this will improve the quality of medical care. Is it right? But the situation is more complicated. Medical error is a complex phenomenon. It always hits both individuals and institutional level. Personally, it affects patients and their families with complexity of feelings, guilt, shame, isolation, fear. And as it was mentioned in recent survey, errors contribute to adverse mental and emotional effects on the involved healthcare professionals. Among them, there are burnout, lack of concentration, post-traumatic stress disorder, moral distress, and many other issues. Above all, silence and evasion breed distrust in the society. One might assume that medicine as an old field and universal field of human practice, and consequently, medical error in different medical settings and their whys and how similar worldwide, and lead to resemblance of medical error and narratives and ethical obligations towards them in different countries. But that is not the case. And to my mind, some of the practices adopted in different countries vary. Some are deeply culturally and historically determined and therefore invisible and hardly measurable without robust research and evaluation of medical practice, legislation, physicians and patients' attitudes and mindsets towards medical errors. I argue that that medical error might be seen as a stigma and consider a moral code of healthcare practice and bioethics in Russia. I have identified two major reasons for negative stigmatization of medical error. First is that we do not have a concept of bioethics, which is well connected to the history and social practice of medicine, and widely accepted by the public and medical community on one hand. And second, we do not have a culture of medical error disclosure. Russian physicians' awareness of error and the potential of harm is well understood, but their attitudes to reporting and disclosure are framed with a culture of non-disclosure and ethics of silence. And the climate of fear-driven medical error in Russian medicine, where traditional paternalism as a moral code is still dominated and errors are forbidden and never should be acknowledged. These aspects led to the stigmatization of medical error instead of considering it as a part of professional risks and area for medical care improvement. So my methodology will just be as interdisciplinary as my career path is, because I would like just to it's always a complicated thing to talk about bioethics from a particular country perspective, because you have to give a broader context for the audience, historical and cultural. So I deployed several works which were published in different periods of time on history of medicine and bioethics connected to the Russian perspectives. There are few of it, I will be honest, because Russian bioethics is not so widely published in English. And the second point on my methodology is a social science and medicine. And I was very interested with the concept that was introduced by medical sociologists from the United States, Fox and Swayze, in their mid-80s, 1980s study, where they argued that it was inappropriate to consider bioethics as neutral and universal. And for the Russian medical professional societies, also it's very interesting to use such a perspective on bioethics, because the differences in fundamental ethical commitments and the historical forces that shape cultures result in different priorities, goals, and understandings of appropriate restrictions on behavior. And these gaps can be difficult to breach. And the non-disclosure culture was enforced through institutions whose employees internalized the non-disclosure norms, as well as through censorship and state's monopoly on mass media that we see in the Russian history and sometimes in the modern society. The second point was that Dan Callahan's works, where he just tried to put a connection between culture in the field of medicine and bioethics. And he emphasized that all individual choices sooner or later create a culture. He also showed that cultural changes influenced by the medicine might almost invisible, but influence our everyday life decisions. This is a two-way process though. The culture of medicine influences moral choices by creating context and limiting those choices. Also, the history and culture of society forms the culture of medicine and bioethics as its part, influencing decision-making and the medical communications. And the task of bioethics is to decide what culture is better for medicine and what medicine would be better for a culture. And public culture based on some of personal choices, laws and institutions that create on their basis. So together, in a Russian case, they form a sustainable culture of non-disclosure where medical ethics and medical errors should never be acknowledged. So, and the first point is connected to the phenomenology, which is necessary to just fix the real lived experience of bioethics. And I will introduce two cases. And of course, phenomenology provides a discretionary perspective for plots of bioethics. And another point, I would like just to emphasize that it's very important for my talk to consider that Professor Barry Lyons and Luna Delizal comprehensively showed the stigma concept within the practice of healthcare in their article and special issue, Shame, Stigma, and Medicine, which I was like looking for, and then I just explored their ideas from my presentation. So just briefly, I would just like to summarize. The culture of non-disclosure is created with by these three concepts: the social history of medicine for the Russian case, ethics of silence as a heritage of our Soviet past, and the current legislation. So, and of course, the phenomenology of medical error is also connected to the very difficult and very clear controversial situation in between the legal narratives and clinical narratives, which also leads to a misunderstanding in terms of rights of doctors to make errors, and on one hand, and on another hand, the protection of patients' rights. And this is the area of bioethics where we just raise this awareness about the patients' rights. Just a second. And I would like just to briefly show why does Russia has no bioethics. It is well known that bioethics was originated in the United States as a part of their academic and social discourse. Although there are some research groups in Russia, independent scholars, journalists working to study these bioethical things, but the country has not seen widespread academic development or widespread public discourse on bioethics. But why does Russia has lack organizations similar American Society of Bioethics or, for example, Zurich University of Bioethics and History of Medicine? The answer is quite complicated. Until the late 1980s, bioethics was not represented in the Soviet academic discourse. This was in many ways due to the fact that it was a product of American academic culture. As the medical sociologist Fox and Swayze told, as I've mentioned before, bioethics is not a sufficiently neutral or universal term. And it should be, and they emphasized that the term bioethics was a neologism which appeared primarily in American culture, and in other culture, its philosophical basis can be perceived as a cultural or transcultural, which can significantly limit its applications in practice, allowing for the use of other terms. In many ways, this is true for both Soviet and post-Soviet Russian development of medical ethics. And we had our own perspective of medical ethics, which were more connected to the deontology. And the main ideas was connected to the ideas of freedom and social. For example, freedom was not individual but collective, which in turn complicated the perception of such categories as responsibility, well-being, duty, and consciousness, which were directly dependent on understanding of freedom. Thus, the individual level of human being was bound to the needs of society, and morality was an instrument of social control that guaranteed social stability. In the public discourse, there was an embryological perspective of a person and the inner life of a human being, which were seen as underdeveloped and in need of being raised, let's say. So in the Soviet period, society was evaluated on an evolutionary scale, spanning from the primitive level to communist forms. And the ethics of silence in this society was shaped by the expansion of the classified zones and non-disclosure demands in the Soviet Union. And the term state secret received a maximally broad interpretation, which led to the non-disclosure culture, and which was enforced through institutions whose employers internalized the non-disclosure norms, as well as those censorship and the state's monopoly on mass media. So these both phenomenons, the ethics of silence and the non-disclosure culture, shaped the Soviet Union, and they are still there in our medical practice. And another point, which is also important, in Soviet medicine, medical privacy received peculiar interpretation. The main ethical goal of the doctor was to aid in the creation of the major truth of the state. So he was a social employer for the state. And policymakers didn't protect the patient's rights to confidentiality, but rather strengthened the non-disclosure culture of the medical corporation. So then this naturally didn't allow for the formation of bioethical institutions as it was understood from the Western perspective. So now we have the similar situation within the Russian medicine. So now I just would like to emphasize briefly the phenomenology of medical error, which exists in modern society in Russian Federation. Here on the slide, you may see when we started just to talk publicly about the concept of medical error. Pandemic increased discussions on medical error. Our Ministry of Health, Mikhail Murashko, told in the February 2020, medical errors annually cause about 70,000 complications in Russian patients. And later in November 2020, he stressed that society needs to rethink its views on clinical safety and recognized the right of medical workers to make mistakes, as they often work under extreme stress. He highlighted the necessity to shift from paternalistic approach in patient-physician relationships traditional for Russian medicine towards responsible partnership. Actually, this is the first attempt on the such level to address medical error problem precisely in terms of clinical practice without any legal implications and criminalization discourse. He also advised creating a special environment for doctors to deal with medical errors. Unfortunately, Russian healthcare system is under permanent reform, and public opinion currently has a largely negative view of several aspects of the quality of healthcare in Russia. So there was a big survey in 2017 about the Russians' opinions about the quality of healthcare. And among their sore points, respondents listed doctors' pew training, 37%, and rudeness of medical staff, 32%. And the study also raised the question of protecting patients' rights. As a result, 73% would support the idea of compulsory medical insurance, a system of state guarantees in providing healthcare, and of insurance representatives tasked with informing people about the possibility of health insurance and protecting patients' rights and resolving disputes between healthcare providers and patients. And this research showed the high level of social concern with the question of bioethics and how these relate to healthcare practice in Russia. So the first attempt, as you see, was introduced by a World Bank report about medical risks and their prevention of medical error. And then we had this big reforms about the investigation committee and medical error concept, which was connected to the ideas of criminalization of healthcare practice. So recently in Russian healthcare, there are two famous legal cases occurred which are connected with the medical error. First is a guilty verdict against Elena Misurina, the doctor whose conviction is a high-profile medical negligence case sparked national controversy. She was sentenced to 2 years in prison in January 2018 over a botched bone marrow biopsy in July 2013 that damaged a patient's blood vessels, leading to his death. And second case is an anesthesiologist resuscitator working in neonatology setting, Elena Sushkevich, who is accused of killing premature baby, and she is under the criminal code article of Russian Federation named murder of a minor knowingly being is in a helpless state by a group of persons by prior conspiracy. Sounds very awful. In 2020, the Russian Society of Neonatologists, and here is here is one of articles which appears in English about this particular case of Elena Sushkevich. It seems that somebody might be interested in reading some more details. So in 2020, the Russian Society of Neonatologists interviewed physicians from all over the Russia about their opinion about the case of Elena Sushkevich. And they've got these figures about what physicians think about this case. And there is a huge tension in the field of medicine connected with the status of medical error, which leads to the stigmatization of medical practice and the distortion of doctors-patients interactions. So, and now I would like just to show you two cases. As I told you, the first would be connected to the institutional things. And what I found is that we have very robust social, legal, and cultural commitments that develop the structural support for medical error stigmatization rooted in the history of Russian medicine and all levels of stigma rooted in the different sorts of physicians' fear of a kind of spoiled identity with the attached possibilities of embarrassment and risk of exclusion of the professional life. And the first case is a hospital administration system of medical error detecting and policy of error disclosure adapted from American Mayo Clinic's experience and GCI standards. And the second case would be a personal story of a physician whose patient died in a result of his unintentional error. And these stories show physicians' perspective on extremely difficult problem of medical error stigmatization. So here on the slide, you can see the brief story about who was the patient. So the ground for the so the the person whom I contacted, she is a deputy chief physician in the big regional hospital, big regional hospital, and they tried to deal with the establishment of the system of medical error detecting. And what she said for me at the first time, we are not punishing anyone for 6 years. No matter what happens, we do not impose chastisement. They established a digital system of registration of incidents in their hospitals. And it is important to take into consideration that this is unusual practice for Russian hospitals. I would say that we might have not more than 2 or 3 hospitals which has such a system for digital detection. So when he first started to introduce in this system, the doctors at the hospital said, "He will be snitches. We will complain about our own." You can see on the slides this quotation. And after a while, doctors realized that firstly, if they post some incidents, they will get nothing for it. And the second, they saw feedback on their incidents. Because if an incident occurred, it was taken apart by a small group and an answer was given. And what can be done to prevent this from happening again? So some kind of working instructions appeared in this hospital, and the administration organized a working group on medical errors and said, let's look at these incidents. Let's build some kind of process standards so that this doesn't happen again. And the involvement of the entire team and the process let people begin to take the initiatives themselves. So when the case of medical error occurred, the hospital were ready more or less to address this issue. So I will just introduce you a brief story for this patient. We have, from the perspective of this physician, we had a gynecological woman. She had a problem with the uterine fibroids. She went to surgery. During the operation, the physician's team left a napkin in the cavity. After 3 days, her condition began to deteriorate. She had a fever. She was taken to the operating room, and they took out this napkin and transferred her to the intensive care unit. And when she began to recover, the team began to think what to do with it and what situation occurred. They started to think, shall we hide this case like we used to do it before? And the chief physician decided to speak openly with the patient, and the doctor who operated was very deeply shocked. He was afraid. And when we began to restore the causal relationship to answer the question, why does it happen? Why did it happen? This happened because not everything was smooth during the operation process. It began with the fact that the woman was going to the operation. On the day of operation, the doctor comes running and says, "You are not going to the operation to this patient." Why, she asked. "Because your sugars are high." And without looking at her bracelet about her surname, she was told, the doctor told, "You will not go to the operation," but she was first on queue, this particular patient. Then the doctor came again and said, "No, you not the first patient. No, you cannot be taken to the operation room because the circle is busy." And patient waited. They took her at 3 o'clock. The shift is already ending, and in the operating unit, everyone was nervous, and they did not want to operate after 2, this particular team of physicians. And now, as this deputy chief physician told me, they made a different process, but at that period of time, that was a very big problems with this organizing the operation. So there were 5 people in the operating room plus 4. Why plus 4? Because the team is changing, and the one comes on duty. In this mess, the nurse, nobody knows how it happens, made a mistake, and they forgot the napkin in the cavity. Then the woman recovered, and the chief physician decided to openly talk to her and to her husband. And as patient remember, at the beginning, everybody was afraid to speak. And especially patient was very concerned because she thought that they would like to tell her about oncology. And when the chief doctor came, he told her everything, and she was so upset, she cried, and her husband came, and he was also told, and patient and her husband said, you know, the main thing for us is that she be healthy, do what you want. So the situation was just very good in terms of results. And as the chief physician remember, they created their environment of trust with this particular family, and they wanted to just promote these ideas among other hospitals. So this case shows us how it may be done if the hospital administration is interested in doing such things, in doing medical error disclosure practices. The second case is another story of my colleague, and he was not so lucky in terms of work in the hospital where there is a culture of medical error disclosure, but he was very concerned about how to avoid these errors in the future. And he was not able to disclose this case with colleagues and hospital authorities because of multiple reasons. And his slogan when we started our conversation, the concealment of medical errors is a reality of Russian medicine, he said. So you can see on the slide the story of the patient, and it's interesting for me because this is very complicated case that he described, and they had within the medical unit several conversations about how to deal with such case. And oncologist offered to perform surgery on her in order to remove this metastasis. And it really interfered with her life. So because the person coughs, suffocates, the metastasis is large, the operation is initially dubious according to the practice of such level of oncology, because in these cases, operation is made on the patient for secondary metastasis. And in general, it's a 4th stage of the disease when surgical methods are of secondary importance. So that was the first question for this physician. And the second was, is this particular tumor was conditionally resectable because it was very close to the heart. So all these things were very complicated because there was no understanding, will the patient will survive after this surgery. But sorry, you can see on the slide the physician's explanation about how they thought about what should be done in terms of this particular patient. And so before, of course, before the surgery, they talked to patient, and they described all complications and risks which may occur after and during the operation. But of course, they told the patient that of course they would try to remove only the metastasis, but the patient said, do at least something, because she can't stand these conditions. And of course, during the operation occurred very complicated situation. And the physician said that his assistant told him at the very beginning of the operation, when they opened the chest, we need to make a decision and end the operation with exploration. Exploration is when the chest and abdomen are opened and closed without doing anything, because functionally nothing can be done. And my colleague physician who's telling me this story said that he called for patient's oncologist and asked him to come to the operation room. And you can see on the slide what he said, this oncologist. And of course, my colleague physician answered him, I don't know if I can delete it or not. In general, I can try, but it may turn out that nothing will come of it. And of course, he tried. They removed her lung and she died the next day, which was generally natural, as my colleague said. This is called medical error, exceeding the indication for surgical treatment. And of course, while conversation that we have, I asked him, what are the reasons for such a mistake? Because they have several concealings, they talk to patient and they even talked during the operation. And all aspects of what can be considered from a universal human point of view, that we were led by the patient persuasion. It's irrelevant things to the opinion of my colleague physician. And medicine is a formalized thing, and there is no such point. I was asked, I did something. In fact, any doctor has such examples where he exceeds the indications for surgery. They may be different aspects of the fact that the patient persuades the doctor that this is the only one way for cure the patient and the only possibility, but that was a collective mistake. And it's interesting what he thought about the possible reasons, his personal reasons, why he did this. And he said that he was too much confident in his power. So he have been thinking that he can still do it. It's what was very interesting for him to just reflect on this experience. And during the operation, of course, he tried to save the patient. And when I asked him why you did this and what conclusions you may get from this situation, and he said that he, of course, have to be more precise in terms of evaluating the reasons for the particular operation. And of course, he has to think more precisely about what kind of resources he has, because the medical details of this particular case are wider that I showed you, but it's not the case for the particular conversation during our workshop. It's too medical to my mind. It was hard to understand what kind of resource he didn't have during this operation. And it's interesting that these two cases highlighted different levels of medical error causation. And what said to me this particular surgeon when I asked him about who knows about this case, he said, my friends, my colleagues and friends within the closed chat in social media where we shared these cases, because within the medical community, I cannot share this case and I cannot talk about this case and I cannot ask for help, never mind professional, ethical, clinical, or psychological, because during the conversation, I've realized that he wanted to share this case, not only because he wanted to help me to understand more about the medical error disclosure culture in Russia, but also because of his will to just become free from this hard story, hard personal professional story. So in conclusion, I would like just to show briefly levels of medical error stigmatization which occurred during this brief conversation: legal, historical, cultural, and social. So the first is legal. As I've told you, the medical error concept is a part of criminal law in our country, but it's not occurred as a medical error, as a concept, as a term. It's like a situation where we use the term, but we do not have it addressed in the legislation. But nevertheless, medical error is not disclosed because of criminal prosecution. Another point, which is connected to legal, we have more legal narratives. If you look at the publications, which are mostly in Russian, you will find only legal publications, not medical professionals, not bioethicists, but more legal or lawyers or whoever who writes about these medical error things. But they write about these things not in terms of ethical implication, but more in terms how to improve the investigation of medical errors. And the third point is because of all these things, errors are forbidden to disclose. And because of social tension between patients and doctors rise, this situation is very stable. The historical levels is that we have very interesting transformation of medicine during the Soviet past, which is still influenced the paternalistic relationships between doctors and patients. And in nowadays, of course, we have the private medicine, the big hospitals created by foreign companies, but in many cases, in many Russian regions, doctors are still state employers. And so we also have this memorial history where Soviet doctors' plot in 50s occurred, and it was a very big problem for our medical community during the whole Soviet period. So the cultural thing is what we discussed with my colleague, that tradition in terms of paternalism dominates medical culture in Russia in all levels of communication: doctors, patient, and doctors family, and doctors hospital. So it's not only the paternalistic approach within the idea of towards patient, but also within the whole medical system. And so scattered medical community, we've never had the professional community which addressed ethical issues from the very beginning. So it's a very interesting point that influenced the bioethics development. And this hidden supportive environment, which I mentioned, and it's very interesting for me area for further development and for further research, that these closed chats of physicians where they share their difficult ethical stories and medical errors and discuss it. And this situation led to fear-driven medical ethics, as I told, not shame-driven in many cases, but of course we have this understanding of shame-driven medical ethics. But the very important concept is a fear-driven medical ethics. So the social, as I told you, this patient distrust, and I told you about this first case, and this was the case of big hospital. And it's interesting observation that I've made while preparing this paper, that medical tourism shapes culture change towards medical error. We have state strategy for development of export of medical service, inbound medical tourism until 2020, and it makes the difference. And this particular hospital is on the queue to be included in this big system of hospitals which are allowed to provide this medical tourism services. And Russian clinics are seeking to obtain GCI accreditation and assure that organization standards, training, and processes meet the highest international benchmarks. And currently, we have only 5 clinics in Russia hold this accreditation. So in terms of medical tourism impact on ethical development in Russian hospitals, it sounds very promising. And that's why I think that doctors as a very vulnerable groups because of this complex situation within the cultural and history and legal situation within Russia. So two decades ago, the Institute of Medicine in the United States published a report, To Err is Human. And this broke the silence that has surrounded medical errors and their consequence in the United States. This didn't happen in Russia. And despite the fact we also have medical errors, the differences is that medical error is not a sphere of professional ethical evaluation, but potential criminal law object. And due to differences in the cultural and psychological attitudes, as well to the differences in healthcare organization, medical error is stigmatized in Russia. Consequently, we do not have official data on medical error. We do not have a hospital detecting system. There are few exceptions now, as I told you. And over the last 20 years, it has become increasingly clear within the health professions that honest communication about medical errors is a significant part of professional responsibility. And the Russian Medical Professional Society do not merely identify disclosure as their ethical obligation. And of course, medical culture is less overtly punitive than it used to be, but the guilt and blame are internalized, often savagely by its practitioners. And it has to come from inside the medical world, and it helps to start at the top. And what matters for me, what can I just suggest as a possible perspectives how to improve the situation and how to destigmatize the medical error. Of course, the first step is education, where I can just make an impact and where is my area of responsibility, because I'm teaching medical students at the first and the second year. Of course, the developing courses of clinical bioethics, working with the public opinion, legislation reforms, because this is the area where medical community, if it will be organized, may just influence their results. And of course, advance clinical settings policies. And what now I would just think about to make my personal input in this particular situation. I've started to work on the collection of national bioethical cases, including medical error cases, because I would like to increase the ethical literacy of medical students, not physicians who are working, because of course, they will not listen to me. But for medical students, I can do this. The second, the transparent discussion where I can on medical error within the professional community and try to just create the environment for such conversation. And I'm working on this direction with the physicians who are just open to this kind of conversation. And the third is very important, which I've already done, is expanding interactions. I've invited several experts in the field of bioethics, physicians from different countries, because it's, let's say, more safe for Russian medical community to talk on medical error or bioethical issues if they are talking not about the Russian reality, but from other countries' perspective. And they are very safe in making judgments and reflecting on issues. But still, I think it also increases ethical and bioethical literacy within the professional community, within the students community, and within the public opinion, because of course, these particular physicians who attend this kind of activities also brings this knowledge to their patients, to the community. So thank you so much for your attention. And I'm so sorry for my not very well organized presentation, because it's always complicated to just deliver this historical and cultural thing. And you have to just use more time to explain basic things. Thank you.
Thank you so much, Nataliya. I would like, could you please, Barry, please go ahead and with the feedback. Barry, mute your mic.
Sorry, thank you very much, Nataliya. It's as I said to you earlier, it's always really interesting to understand how medical culture, law, regulation operates in different environments in different countries. I suppose there are a few things I want to say, which I guess are an attempt at some sort of a comparison with how all of this operates in my world, and then a little bit about the two cases that you presented, and maybe a little bit of a distinction in how we might think about those two cases a little bit differently. So the first thing I want to say is about medical culture and changes in medical culture that happened, I suppose, initially in the US from the 1960s onwards, and a philosopher, theologian, Hans Jonas, in 1969 made this sort of, in talking about medical ethics, talked about, he said, the physician is obligated to the patient and to no one else. The doctor is, as it was, alone with his patient and God. And there was this sense that there was nobody else in this equation other than the patient and the doctor. And you talked about Fox and Swayze, and my favorite book about, I suppose, what were considered to be interlopers, sort of invading the space between doctors and patients, is David Rothman's Strangers at the Bedside, which is a social historian's account of how bioethics, I suppose, initially began to influence medical culture in the United States. And he talks about this whole variety of people who suddenly began to question medical decision making, especially at the sharp end, and a sort of a group of misfit philosophers and lawyers and judges who became involved in raising questions about how doctors addressed certain issues of moral significance. When it comes to error in itself, it is and has been always a significant issue in medical practice, and the matter of truth telling always an issue of importance to patients and reticence on the part of medical practitioners. And if you go back as far as the Hippocratic Corpus, there was no requirement within that for doctors to be truthful. In fact, for them to be parsimonious with the truth with patients. And the jurist Oliver Wendell Holmes in the United States had this quote when he spoke to medical students in Bellevue in the 1870s, and he said, "The patient has no more right to the truth, to all the truth, than he has to all the medicines in your saddlebag." And so that issue around patient entitlement to information about things that we now consider to be certainly within their entitlements is something that has a long and protracted history. And part of that, I think, is because there are tensions within the system. There are tensions between accountability mechanisms and what we have as an overarching aim, which is the improvement of patient safety and the reduction of error and harm within the medical system. And those tensions lie in, I suppose, the conflicting roles that regulators and law might have on the one hand, and what institutions might aspire towards on the other hand, and that tension between blame and no blame cultures, between a form of regulatory shaming on the one hand and a supportive environment on the other, are things that certainly in the West we have in no way succeeded in balancing in any shape or form at all. And I guess just to think about how we might think about these events, I just want to tell, I suppose, a story that of a case from 1987 in New Zealand of a doctor called Dr. Yogasakaran, who, for anybody who's not familiar with the medical era literature, probably would be unfamiliar with. So Dr. Yogasakaran was an immigrant to New Zealand, and he worked in a small rural hospital where he was supposed to work only under supervision. And a patient came in who needed her gallbladder removed, and she had a lot of what I suppose we call comorbidities. She had a lot of other illness issues that made the case complicated. And interestingly enough, all the anaesthetists there decided that Dr. Yogasakaran, despite his status, was actually the most skilled anaesthetist and should undertake the case. And at the end of the case, the patient ran into some breathing difficulties, and there was an emergency whereby her oxygen levels fell. And though Dr. Yogasakaran went to the press and got out a drug, which he thought was Dopram, and that's a respiratory stimulant and would normally be given, the whole AMP would be given. So he drew it up and injected it into the patient, who had an immediate cardiac arrest. And they tried to resuscitate her, and they called the team from the larger hospital who came and retrieved her, but the woman died. And Dr. Yogasakaran couldn't understand what had gone on, and he went and got the vial back out from the bin to discover it wasn't Dopram, but dopamine, which is a cardiac drug, and the injection of that amount would be fatal, as it was. And he rang the larger hospital and said, look, this is what I've done. I don't know if it'll make any difference. So he acknowledged what he had done. Under the law, the Criminal Crimes Act of 1961 in New Zealand, the subsection on duties of persons doing dangerous acts, Dr. Yogasakaran was charged and convicted of manslaughter. And even though there was a testimony from a psychologist at it to say that under stressful circumstances, the vial, which looked very much the vial that he would have used in his native jurisdiction, and having read the first three letters, he would have automatically assumed it to be what he thought it was. That conviction was upheld in New Zealand. And it leads us to sort of ask questions about responsibility and what we might think of Dr. Yogasakaran. And sometimes we think he was an honorable doctor who tried his best under very difficult circumstances. And on the other hand, there is still a patient who is deceased. And it can be very difficult and conflicting. In medical circles, that case raised huge issues and ultimately led to a change in the law in New Zealand. But from a patient's rights perspective, there was a conflicting narrative which said, here's a woman who goes into a hospital for a routine operation and dies. And those tensions between those narratives are things that, even though the law may be clarified, are still things that create tensions within our environment. The second thing about Dr. Yogasakaran's case is that it created or inflicted a cultural change in terms of secrecy. Nobody was going to admit to anything under those circumstances when you had the possibility of criminal conviction. And even though there was no penalty associated with the criminal conviction, the shame of criminal conviction is still in itself a severe enough penalty to damage, I suppose, a medical practitioner's both self-respect, self of themselves, and also I think their employability in certain circumstances, especially as an immigrant. So how the law and regulation interpret medical error has not managed, I suppose, to resolve the tension between the protection of patients and the need for openness and disclosure on the other hand. The way through that, I think, is twofold. On the first, I think it is the need for bioethics education of medical students as they go through to understand proper relationship between patients and practitioners being one of partnership and being one of sharing and being one of an understanding of the rights of the patient to full knowledge of their medical issues. That is easier said than done, because as an educator, you can educate people in this. The difficulty with it is, I guess, what's called the hidden curriculum, which I don't know if it's which is a prevalent concept, I suppose, in medical education. And it's the idea that you can teach people things in a classroom, but what they mirror is what they actually see in practice. And so we can talk about rights, and we can talk about disclosure, and we can talk about partnership in the classroom, but when this is not what's visible in the clinical situation, then it's not absorbed in the same way. You've got a prominent counter narrative that is often mirrored, and that's what makes it very difficult, I think, to change things in practice, particularly over a short period of time. So all the changes that you propose are valuable and important, but also hampered by prevailing culture within institutions and organizations. The value of disclosure and discussion and openness within environments, I think, is important in the first case, which was the case of the retained swab. And what we know from discussing lots of cases like this is that, and so interestingly, the first NHS circular around retained swabs was issued in 1972. So it's been noted for an awful long time. It's now called a never event in the NHS, but it still happens. Never events are never, never. And what we know from discussing all of these and the circumstances that you talked about is that if you have distractions in the clinical environment, people will make errors. And that is what comes under the science of human factors. And we know that humans in particular circumstances will simply make errors. And the fallibility of the law and regulatory process is that it fails to recognize what happened in Dr. Yogasakaran's case and take it forward, which is the distinction between what we call errors and what we call violations. So errors are psychological slips and mishaps that they happen to us when we forget to bring our keys with us. They are standard things that happen to people every day, people with good intent who are doing their best, but the circumstances prevent them from completing a task or from omitting a task, whereas violations are deliberate things that people do in order to circumvent the rules. And so there are, in my specialty, there are numerous examples like anesthetists who leave the operating theatre and with nobody in the care of the patient, and the ventilator becomes disconnected and the patient dies as a consequence. Under those circumstances, that's a clear violation of your professional responsibility. And law and regulation fails to make an appropriate distinction between errors and violations in the way it thinks about them. And the second case that you presented is interesting, because what I think, so in this country, and I think Diane, I saw had posted in chat, would not be considered a medical error. So this would come under what we might regard as a right to try. So somebody in a desperate circumstances who says, I will die without this, I may die with it, but I'm willing to take that chance under the circumstances. What you have, though, is an emotional response on the part of the operator, which is, that was a bad death, I wish I hadn't done that. So there is a similar sense of shame of having done the wrong thing. But I suppose in a legal sense, it doesn't constitute a medical error. So all of these things, so openness and transparency are so important for helping us move forward, for recognizing good practices from those that are fallible, from those that are dangerous, from those that will impact negatively on the welfare of patients. But unless we create an environment where people feel free to openly disclose things, then it becomes very difficult for people to be willing to do that, to expect people who pride themselves on perfection to disclose imperfection is a very difficult thing to do. When there is punishment at the end of that, it makes it doubly difficult to achieve. And so we have this tension that is not yet resolved between the two parts. I will stop there because I've gone on for long enough, and there are, I'm sure, lots of questions.
Thank you, Perry. Nataliya, do you want to respond to any of the comments, or?
Yeah, of course. Thanks, Barry, for your valuable perspective on this talk, because as I've told, it's more like work in progress. And what is more important for me from your comments, I just make some notes. First is that you highlighted for me the very important point that we have to just try to find what does we mean when we are talking about medical error, because as you've noticed in my presentation, I used quotes. So this was the physician's understanding that it was a medical error. I understand that in many cases, it shouldn't be considered as an error. And personally, I do not agree with him that it was an error, but he thought about himself that it was an error. And of course, it was very difficult for him not to have this safe environment to talk to colleagues, just to share this result and to get this, let's say, response like you gave me now, that it's not an error and just we have to be fair in this situation. This was one point. And the second is very important for me because in our language, we do not have these two errors and violations. We have more this negligence or even, murder. So it's quite a complicated case for me just to mix all these terms together and address these terms within this, let's say, universal medical practice environment, because of course in many countries surgeons do the same things in operation rooms, but when we are talking about their personal understanding of what they are doing and what are their results and their feelings about this, it's very different. Of course, also, which is also connected to the language that they use. And Barry, thank you so much for your comments. And I will try to just go deeper according to your recommendations and literature also. Thank you.
It was a real pleasure to read it. Thank you very much, Nataliya.
Nataliya, do you want to comment on to some comments, which is on the chat box, or? Dan has had a comment, I think, which you clarified.
Yeah, and it seems that I've already answered on Diane's comment because I just tried to explain that it was not my, let's say, evaluation. It was this personal physician's opinion on what he has done. And
Wendy, who? Yeah.
Social media, no, social media is a safe place. I have to explain. Physicians created their personal chats within social media with small groups. I found this from several conversations where they can openly speak about these errors, ethical concerns, other things, because they had no ground or environment or community where they can speak about this, but their will to speak and their let's say they need to speak, they have these needs, but they cannot do it openly or within the professional community, only in closed chats. So that's why I said that they have this safe space in social media, but I was not very precise in addressing and explaining. We highlight all, I'm sorry.
Right.
Just a second. And that concern, yeah, how is it alter that can be formed? No. We also have the special groups on Facebook and Russian social networks and social media, where people, physicians, and not only physicians, but also patients share some cases. But, you know, when things occur in media or in outlets publication and then reposted to social media, it always increase anxiety. It always increase the tension. But for physicians, I wanted to emphasize that they have closed environments that they created themselves. And for me, as a researcher, it's very interesting to go into this environment and try to understand how it works and how it can be, let's say, expanded or even transformed into educational settings where we can use this conversation for medical students teaching. So, I'm sorry. Okay.
So,
I think there are two things. Yeah. Yes. So,
if there are any other questions, we can wait. But I have a question or a comment. I don't know. Like, I'm thinking out loud when we are. Betty, do you wanted to ask something?
No.
Okay. Sure. So I was thinking, I mean, in countries, especially when there is an authoritarian regimes or when there is not a very democratic values, and the larger political system doesn't open up with the value systems, which is like more open, transparent, which even Betty was referring to, right? And where you tend to keep it to yourself. So coming from Indian perspective, I mean, when I was discussing with some of the doctors, they used to say, I mean, well, still within India, still people do engage and, discuss about the medical errors, but not in a very open way, of course. I mean, I think it's not just with developing countries versus developed. I think there's always a challenge in both settings. But within even the community, medical doctors community, they do talk about the close setting, the secrecy. It's like fraternity works, right? I mean, even within the doctors, for example, if there's a death because of some error, they tend to, in Indian, some of the doctors did mention this to me, they do an internal audit. So is there a practice which upholds the patient's safety standards within the Russian settings? I mean, while making sure the doctors are safe enough within their own community, but they try to protect patients and patient safety standards are upheld.
Thank you for your question, Supriya. I would say, since I'm not a physician, I cannot be sure that I know the whole reality, but I'm sure that we have very professional physicians in terms of they are doing their best. And of course, for patient safety also. But for me, it's very important to consider medical error not as a part only for clinical practice, but but also for educational reasons. And not only for medical students, but also for medical professionals. Because if you are talking with your colleague about what had happened within your clinical practice, you can just increase his or her awareness of the particular case, and perhaps in many cases to help he or she to increase their patient safety within the clinical setting in her particular clinical practice. So I hope that the answer for your question is yes, they are doing their best, but I cannot be sure because since I'm not a physician, so I'm sorry.
Sure. Thank you, Nataliya. If there are any questions. Yeah, Dawn, please.
Hi, yeah, that's really interesting presentation, thank you. And it's not an area I know much about at all. But just reflecting on some of what you were saying, what Barry was saying, it sounds like relationships are important. So, you know, preserving a sense that although you acknowledge maybe, I mean, it might be normal human error, or it might be some negligence, it may be some kind of wrongdoing, but I guess it sounds like you're talking about being able to acknowledge that, but still preserve a sense of acceptance and belonging and not necessarily being ostracized. And I was just thinking that, you know, it kind of mirrors the distinctions often made between shame and guilt. I'm not suggesting that the way forward is to foster excessive guilt, but it's, you know, it's thinking about what seems to be problematic here is the internalization of that as shame, and the process of shaming and feeling alienated and ostracized. And I've wondered before, like I said, this isn't an area I know much about, but does anybody ever draw any parallels between any of the criminological work on restorative justice or reintegrative shaming? I don't know a great deal about that literature, but I know some of those ideas there about preserving relationships and a kind of more productive acceptance of wrongdoing. I just wondered, is anybody drawing on those ideas in the literature around clinical investigations and never events and things? I don't know.
Will I answer, or, oh, sorry, do you want me to? So it's an interesting thing. So Atul Gawande wrote a book called Complications, and within that he sort of addressed the sort of safety literature. But there is I think it's in that book, but there is a bit where he talks about an error of his own where the patient nearly died, and he draws this distinction between shame and guilt, about the difference between the act and the person, and he said, you know, this was shame, this was not guilt. It wasn't that just that the act was wrong, it was that I was wrong. And there is this, and I think so from a personal perspective, as somebody who was brought up in a Catholic environment, I find the distinction between guilt and shame very difficult to draw very neat lines down through. I think it's, and Juanita, who was on earlier, who's from Colombia, we had this conversation once about one's upbringing and about that distinction sometimes as being, you know, that there is no guilt without shame in certain circumstances. So there are things to be thought about there, but I do think that focus on the act rather than on the person would be a healthier way to examine both ourselves and events that happened, and because good people make mistakes, and suffering in a long-term manner as a consequence would be a bad thing for everybody. From a humane point of view, it would be bad for the doctor, but even from a patient safety perspective, it would lead to somebody's loss of confidence and inability to, I suppose, perform to the extent maybe that they had done before. So I think it's, even if you wanted to take it on just a purely utilitarian calculus, it would be better to make that distinction within this sort of regulatory environment, and so I think that would be important. The other question that you asked about restorative justice is really interesting, because it's something that I think about a lot, and part of the difficulty with the narrative, certainly in the UK and Ireland, because we share a similar regulatory system when it comes to medical practice, the GMC is founded basically on a 14th century exclusionary model. So that is its ethos, and it has never really changed that ethos. And I think the Bioethics case made that extraordinarily clear, that it still retained that kind of model of operation. And I think it is incredibly unhelpful and creates a very, it makes it difficult for honesty to be fostered and to grow in that kind of an environment, because people will always be afraid, as Nataliya said, of losing their job, their livelihood, and their life in a certain way, because many people in medical practice identify with their role. It's not just, it's that their identity is, it's not just a job, it's that their identity is tied up with it. And so I think that there's a need for a radical change from that exclusionary model to a much more restorative model. I think that that would be a much healthier place for everybody to be. But whether the lawyers would embrace it or not is a different thing. That's.
Thank you. Nataliya, there are comments. I think, sorry, not for Nataliya, I think it's addressed for Barry. By Wendy, Wendy, who on the chat box.
Yeah, and I think, I suppose that's something, structural issues. It's something that we haven't addressed, which is that. So when I talked about human factors, what we know is that, so there's a thing called the Swiss cheese model, which I don't know if people are familiar with, but the Swiss cheese model is that basically every organization has these barriers, so that if somebody makes a mistake, there are safety nets along the way that prevent the error from reaching the patient, but that there are holes, because it's Swiss cheese, there are holes in the cheese, and if the holes all line up, then what you get is a kind of a perfect storm where the error actually reaches the patient. And oftentimes this holes in the Swiss cheese line up because of the system. So there's a whole, whenever you investigate these events, you find a whole catalogue of events that led up to this particular situation that meant that the patient was harmed. And Nataliya's first case about the retained swab is exactly that. It's all these people in the room at the one time, it's the changeover, it's the, you know, the unfamiliarity, it's the chaos, it's everything all arrives at the one time. And it doesn't really matter whether it's medicine or airplanes or ships or whatever. And as somebody says, it's whether it's burnt dinners. It's about all these holes lining up at the right time. And the problem with, we understand that from a psychological science perspective, but yet whenever there is litigation or there is blame or anything, it is the single individual who ends up as being the recipient of all the blame and the harm that comes out of that. And so there are many things that we understand from system science and human psychology that tell us about how these things happen, but very little integration of that into the systems that review these cases and interrogate them and end up, you know, in dealing with them in a punitive kind of a way, which is why restorative engagement is just so much better, because then families can understand how these things happened, and there's, you know, it's a much healthier place to be.
Right. Yeah, that's true. And I was wondering just like about no fault compensation within Russia. I mean, do you think that does state would take it? I mean, how would you think the state would respond to that? And do you think it would also help people? I mean, especially the physicians?
Supriya, I'm not sure that I understood the question. Would you please repeat it?
I mean, in the sense, like when there is a medical error, right?
Mm-hmm.
And for example, right now, the criminal, it is within the scope of the criminal law, and it can go to the medical negligence point of view, but at the same time, if there is no fault compensation, some of the systems it functions, like when there is a medical error, but the state would take it, but there is no blame for one individual, but then they'll make sure the system is in check, the larger, and then it's more of a preventive, and then takeaway learnings would happen. I mean, at least ideally, that's what, as I understand, should happen. But in the first case, the question was I was asking is whether in Russia, even do you think that the idea would even would be possible? That's the thing which I was thinking.
As far as I understood your question, you are asking me about the insurance for this medical error from the state, not?
It could be there, but then is there a system where the state would help, but not blaming one individual, but then removing that blame and then compensating the patients or the patient family members, but focusing more on a systems point of view? I mean, of course, the larger discussions which we were talking about it, right? From a legal point of view, I was referring to.
Typically, if such cases occur, patient or his family go to the court, and then they ask for a compensation from the medical setting or hospital. Generally, if hospital is a state hospital, so this is the area of responsibility of the state. So through this medical setting, I mean the state medical setting, state pay to the patient the compensation. But if we are talking about the kind of structure which will help just to, let's say, protect physicians, it's hard to imagine how it could be addressed within the current healthcare system and legislation, because this investigation committee, which I introduced during my presentation, it was established 10 years ago. So they have to do something, and towards medicine also. And this medical error investigation is their area of responsibility. And so for me, it's a very complicated question that you asked me, because so many state of administrations, or let's say settings, are interconnected within this medical error investigation. So to my mind, it's very hard to address, except of medical community will try to push this question to the direction that they need to address it. But as I've showed, medical community, let's say, choose not to talk about this. And of course, they are trying to build this environment sustainable. And they just, let's say, they have this habits in terms of they are playing by the rules. So that's the point.
Yeah, I mean, sorry, Barry.
No, I just wanted to ask a quick question in relation. I suppose, and it's about so Russia's a huge country, and is there, I suppose that, and this is probably the case in India, is there regional jurisdiction over the individual laws, or is that a whole country sort of piece of legislation? Do different regions have different pieces of legislation?
Yeah, we have these different levels. Of course, we have the federal level of legislation and regional level of legislation. But in terms of medicine, the standards of care is federally regulated. So even if you are, for example, in Siberia, you have to follow the federal law, and this big federal law on healthcare and medical practice, which let's say have to be followed by all clinical settings. And these clinical recommendations and all instructions and orders from the Ministry of Health of Russian Federations have to be implemented in all regions. Of course, in regions, they have additional laws in terms of financing some sorts of care, of medical care. But it also always depends on how rich region is. So it may be a region donor or a region recipient, so using this medical terminology. And it depends on what kind of what kind of service they can provide according to their budgets, in addition to the federal guaranteed service, I would say so.
Okay.
I mean, I was just thinking out connecting Barry's talk on, stigma and mental health, and then connecting even the medical era, talking about it. How would both of you consider the term error to use? And do you think that would create in itself certain aspect of like shame and stigma to talk about it? And it would have, of course, affect the mental health of the practitioners, of course, right? So, so should we use a term of error, and or is it's okay? I mean, what is your thoughts on that?
Barry?
so yeah, so I mean, I suppose when I originally met Luna and we were talking about this 5-6 years ago, I mean, this I suppose was my starting point, was around I suppose what we think of, or what I think of, as regulatory shame, and I think that this the use of words and terms is really, really interesting. I don't have a better one than error, but I think that I think in its definition it makes sense to me, and I think the distinction between errors and mishaps makes sense, but in common parlance it doesn't necessarily help. And I think something less judgmental that's less judgmental in common phraseology would be helpful, but I don't have a substitute for it. But I do think it is a really good point, because language matters, absolutely. I don't know, can you think of something else, Supriya, that we could pull?
I'm not sure in this domain, but it just occurred to me, you know, like I was just connecting these two presentations and I was like reflecting on the language, because I'm curious if that, yeah, please, Nataliya.
Yeah, I have something to add. You know, when I'm trying to prepare this presentation, I use the English term medical error, but in our everyday practice, we have physician's error. So if we will translate directly from just cover to cover from Russian into English, I have to just introduce to you the physician's error concept, because it's deeply personalized understanding of error within the medical practice and healthcare practice in Russia. So it's not, there is no term medical error. We always use this physician's error concept. So it makes sense.
Much more scarier, I feel like. I need to much more.
That's the point.
In your regional dialect, or Supriya, do you what sort of words are there? Different words for mistakes or error? Or I had a fascinating conversation with Juanita around shame in South Americans or Colombian Spanish, and the words that they use, which is really interesting.
That's true. The language and the terminologies which we use for different different cultural contexts and different language. For example, I come from Karnataka. That's one of the southern Indian language, and even within that each context, the term for shame or sometimes nachke can be even shy. Understanding the shame could become even shy. Understanding the concept in itself. So it's very context specific as we talk about it. And but the shame, especially within the context of medical knowledge or medical settings, it is very often disrespectful idea. It's generally a bracket statement of disrespect, but also sometimes disgust. So we can play around with it, and it's very interesting. It's quite fascinating, of course. That
it's really interesting.
Wendy has. Okay, it's a
sure.
comment. But
yes, it is. It's very hard to
True, but this has been quite very fascinating and engaging discussion, and thank you so much, Nataliya and Barry, for this interesting session, for this 4th session of our workshop series. And I'm really looking forward for the last 2. I mean, the next is on December 3rd for the rest of you. And but thank you. But is there anything else? Do you want to comment or final anything?
No, I just want to thank Nataliya. It was really interesting to read your paper, and thank you very much.
And I would like to thank also Supriya and Luna for this fascinating workshop series, because it seems that you raised very important questions which are very underdeveloped within the healthcare practice and medical settings. So, and I would like also to appreciate Barry's comments and reflections on my paper, and everybody who joined our session today. Also, my appreciation. Thank you so much.
Thank you all. Thank you for all the
Thanks,
participants here.
you.
Thank you, Barry. Thank you, Nataliya.
Bye.
Bye.
Bye.